All right, thank you very much. So, SCCT finally comes to my home country of Canada, so it's a pleasure to be here. And the topic actually is very much in line with what the theme is, at the heart of it. I'm going to talk about AI and photon counting. And at the heart of AI, I believe photon counting has to be there. We have a lot of AI products out there which are out and about, and a lot of those products have been developed using the energy integrating detectors, all the information that we have from conventional CT. However, now we have the neotom alpha class. With that, we have high resolution. We have photon counting, which is proving that there's more to it. There's more than what we were able to see before. And now I think the paradigm shift will be that a lot of these AI tools need to be trained using this photon counting information and also take advantage of the photon counting information that's there. What is the photon counting information that's there? Well, we know it's more accurate, right? We're already reducing the amount of patients that need to end up in the cath lab. But not only that, we're also more precise in evaluating the disease. And because of this, we're actually downgrading a lot of the patients from different CAD-RADS categories to a lower one. There was a joke at SCCT Amsterdam that somebody said, if you want your patients to be healthier, just scan them on a neotom alpha scanner. But the idea is that, hey, we're actually closer to what the disease actually is underneath and to be able to treat that. But this is not just out of the bloom, right? We worked on this over decades, right? And this is a nice image from MUSC Milan created, which shows the progression, how hardware and software together works to provide us with the excellent image quality that we're working with today. From energy integrating detectors, then adding with somatom force the dual source temporal resolution, and then with neotom alpha, increasing the resolution to spatial resolution to 0.2 millimeters. And then last year when we had the neotom alpha class where we went 3 scanners of photon counting, we also introduced things like Z-free, which gets rid of step and stare artifacts. This is the base. Now, if you add AI on top of this, the benefits will shine further. And here's an example of that. We know FFR CT is quite important in our daily work here today. And we know that step and stare artifacts do exist sometimes, right? But with Z-free, you get optimal image regardless of the detector width. And this has the implication that the CT-FFRs that are computed now with AI, or also in the future more and more will be AI powered, can actually take advantage of the information that's underneath and provide FFR readings which are more accurate. That's just the step stare artifact correction side of things. But the sheer resolution that neotom alpha class brings with the 0.2 millimeter slice thickness also will help in segmentations in these AI tools for FFR. And these, again, have the implication that we can actually change maybe the FFR values. Again, coming closer to what we see as the ground truth in the invasive cath space. So again, getting closer to what the reality is and seeing really what we're not seeing today. But not only CT-FFR will benefit from photon counting technology. Today, we're also moving towards an era of quantified plaque analysis, right? We don't want to just do, hey, what's the stenosis grade, severity, but we actually want to see what this plaque is made up of and maybe be able to act on this. And there, we're going to have tools, AI-powered, which are going to make this as easy and seamless as possible so that plaque analysis information is readily available, but it has to be reliable. And the reliability will only come from neotom alpha class with the high resolution because you are able to see better. And if you can see better, you can actually quantify it better. And it's not just hearsay from my side. There's, of course, a paper out there as well, again from MUSC, which proves again that photon counting detector outperforms conventional energy integrating detectors when it comes to, again, quantifying the plaque that you're seeing. But when we do this, plaque has multitudes of use cases. We want plaque in the future to work as a biomarker. And if we want to do that, we need to establish a standard. We need to establish what is the gold standard, even in CT. And of course, having the good image quality provides that. And again, we can do this for optimizing medical therapies to set those thresholds that we still don't know where it should be. Or even doing drug testing, what would be the future of other drugs that can help in this space. But alternatively, the other aspect is, of course, the interventional planning. This is, again, going in the direction of CT-guided PCI, which will be the next transformatory thing that we're working towards. Again, because you have morphology, stent length, stent diameter, you know where the stent should be landing, and you can also adhere to the normal to normal approach. All this information already coming from the CT scan. This is the problem in the cath lab today, right? You only see the narrowing. You don't necessarily see the extent of the plaque itself, but CT can solve that. With CT, we can really give that information up front. Now, I know a lot of people will argue you don't necessarily need CT. There's intravascular imaging, IVUS and OCT, to deal with just specifically that. And I would say, yes, that is true, but how many of your sites are actually using IVUS and OCT in daily practice, even though we know that there is better outcomes by using IVUS and OCT? The reason is, firstly, maybe the cost or the workflow cumbersomeness, but also, actually, IVUS and OCT have their own drawbacks as well. And these drawbacks are highlighted in this paper, where they looked at a new kind of classification of a stenosis, which you call it the donut sign, where both IVUS and OCT would struggle. IVUS would struggle because of the heavy calcification, and OCT would struggle because it's quite deep. So OCT doesn't have as much depth to it. But with photon counting CT, with neonatal alpha class, we're easily able to diagnose and kind of see this donut sign by using our donut. But of course, we're in Montreal, so here I would like to also urge you guys to try out the local Montreal bagels, which I've heard are better than the New York style, but let me know how that goes. But to reiterate in the end, it's not just AI for the sake of AI. AI has to be built on something. And photon counting technology with the neonatal alpha class provides that platform for that accuracy, for that precision to outshine. And that's more or less it from my side. Thank you.
There we go. Good afternoon. Thank you for having me. My name is Chad Rowland. I lead GE Healthcare's global premium CT business. So I'm going to start today with a couple of images and ask a question. Wouldn't it be nice if? Wouldn't it be nice if we could make coronary CTA as easy and robust as any contrast-enhanced CT? Well, maybe we can. Here's a coronary CTA taken with no ECG leads, free breathing, 78 beats per minute, no beta blockers. Another example, no ECG leads, free breathing, 100 beats per minute, low dose, less than 2 millisievert coronary CTA. Another example, 136 beats per minute, no beta blockers, high quality CT exams, consistent, reliable, extremely easy to execute. This is the foundation for enabling comprehensive cardiac CT assessments. Look, we all are extremely excited about photon counting CT. We're extremely excited about what it can do for the industry, and we're also looking forward to bringing it to market. But the reality is that the world also is going to need hundreds, if not thousands, of new cardiac CTs over the next few years to meet the surging demand for this application. To meet that kind of broad adoption, we also need CTs that are cost-effective, that are affordable, that are easy to use. CTs that provide consistent, repeatable performance for all patients and all users. And of course, don't have a compromise on quality, but can provide that high-end capability when it's needed. So over the next few minutes, I'm going to talk about 3 different areas of novel technologies that GE Healthcare is working on to make this comprehensive cardiac CT available and accessible to more providers and more patients around the world. So it starts first with a cardiac optimized CT, a system capable of providing premium cardiac performance, but accessible for broad adoption. We also want to make spatial and spectral resolution capabilities available when you need it. And finally, we want to bring it all together with automated post-processing tools that can provide consistent insights and reduce overall staff burden in processing. So let's start with the CT. I'd like to introduce you to the Revolution Vibe, providing a new vision for every heart. This is a brand new CT from GE Healthcare. I'd love for you to stop by the booth and learn a little bit more about the device. But it's a cardiac optimized CT designed to provide consistent, exceptional image quality for every patient using unlimited one-beat cardiac. This provides that capability for reducing or eliminating the need for beta blockers, or to do cardiac exams without the need for ECG leads. It has effortless cardiac workflow that's AI-powered to help streamline the scanning process and make doing coronary CTAs available for any user of any skill set. And because we want to make it more accessible, it's designed to lower the overall life cycle costs of running a cardiac CT practice. This is not a compromised CT. It's a high-power CT with innovative technologies, including a 16-centimeter detector to help overcome the challenges of stepping artifacts in complex patient cases. It has high-powered tube at 1300 MA. It has fast rotation speeds, high temporal resolution, the technologies that you need to provide exceptional image quality for every patient. The system comes with the latest deep learning reconstruction technologies designed for cardiac CT to lower noise and boost visual image sharpness to help increase your diagnostic confidence. Ultimately, it's about having a CT that can provide consistent image quality even for challenging patients. High BMI, AFib, high heart rates, mixed plaques, high calcium burdens. The system is designed to overcome these challenges for any patient with one simple standardized protocol at low dose for every patient. Let's talk next about spatial and spectral. So there are going to be cases where we do want that boost in spatial resolution, or we want to leverage the capabilities of spectral imaging. And so GE Healthcare is looking at ways to bring these technologies even to products like the Revolution Vibe. So here's a first example. This is a new deep learning super resolution algorithm designed for cardiac to provide that boost in spatial resolution, that boost in image sharpness when you need it. Another example, whole heart spectral cardiac, providing spectral cardiac imaging so you can vary monochromatic energy levels, like in that middle picture, being able to push up that KEV and help moderate calcium blooming, or generate different material images to remove calcium or remove iodine through the natural capabilities of material decomposition techniques, or be able to create iodine overlays for the heart. Next, let's talk about automated post-processing. Again, our goal here is to reduce staff burden from repetitive manual post-processing tasks. We want to provide consistent outputs and deliver insights directly to the PACS, so it's ready for the read. This vision here starts with the CT. Of course, the CT has protocols to automate the CT acquisition, but now you can build in your post-processing automation directly into the CT prescription, meaning that as soon as the CT exam completes, it will automatically kick off the requested automated post-processing, we call them auto views, to generate things like automated calcium scores or epicardial fat measurements, different coronary reformats, or 4D segmentation views. These images and analytics are automatically calculated and generated in the background and pushed to the PACS within a few minutes, so they're immediately available for a read. Then you go in, if you want to go deeper, move into an interactive review, look at quantitative results like coronary flow, myocardial perfusion maps, or strain assessments. All of these things available in a single interconnected platform, so that ultimately we're creating a post-processing suite that's linked directly into the CT workflow. So in closing, thank you for having us and allowing us to share our vision and some of the technologies that we're working on to provide this comprehensive cardiac assessment and ultimately make coronary CTA and cardiac CT exams available to more providers and ultimately more patients around the world. Thank you.
All right, well, thank you. It's great to be here on SCCT's 20th anniversary. We're really proud to support the society. And at Heartflow, our vision is to have an all-in-one AI platform to enable managing coronary disease proactively for life. I'm going to talk about a couple key themes with this. As we've done now over 400,000 patients with FFRCT and plaque, the importance of being able to learn from and incorporate real large-scale use into how we improve a product, and then how we also see evidence as being crucial along with the technology. The real opportunity we have here is that there's about 1 billion pixels of data in a typical coronary CT data set. And we can visually see an awful lot, but there's a lot left below the surface only looking at it visually. So the future we see is that every CT image will have an AI assessment with it. And at Heartflow, that means images come in, they go through a pipeline of multiple AI algorithms, and then have a human quality review to ensure the best results. But then also now a demonstrated ability where we can take those learnings of hundreds of thousands of cases and all our experience and improve the product and improve the algorithms and validate and release updates. And I'll talk more about that in our products to come. The analogy may be if you do coronary CT and you started at doing 2 a week, and then you got to 1 a day, and then you get to 20 a day, and you learn things and you put things into place that you would never have learned if you only did this small scale. So this large-scale learning really changes the way we do things. And this results in precise, quantitative 3D insights that otherwise wouldn't be seen in the CT images. And then we've really built this into a workflow around the physician. So up front, we give roadmap with stenosis. Every single coronary CT needs to be interpreted for stenosis, so that's provided. And then with the click of a button, almost instantaneously, you can acquire FFRCT or plaque, or both, depending on the clinical need and the medical necessity for the patient. Now, as we look towards the future of how do we keep doing this in a way that AI and physicians really work and complement each other, there's 4 things I'm going to talk about. One is how do we help really see and quantify coronary disease? How do we help make the interpretation and dictation easier as we scale CT programs? How do we help plan and monitor the treatments, and then ultimately help look into the future of how do we predict the risk of our patients? Underlying all of this is AI, and this is obviously talked about a lot. I think the headline "AI is everywhere" makes a lot of sense. You can now get into a self-driving car. There are over 1,000 cleared FDA devices. But there is often this question that remains of, can you really trust AI? And I'm not here to tell you to drink the Kool-Aid and AI is great for everything, but I think it's a fair question. And it's actually incumbent upon us to help provide the evidence that you could trust it for each specific product. And at Heartflow, we have created the most studied AI platform for coronary disease with 100 completed studies, over 600 publications. And it's not just quantity, it's also the quality of evidence that matters, of course. So that means prospective, multi-center accuracy studies versus invasive standards like IVUS and FFR, randomized controlled trials that are completed, prospective outcome studies. At this meeting, the DECIDE registry looking at real-world use of Heartflow's plaque analysis and its impact on patient care was presented. So all of this evidence really matters to be able to say, is the AI actually useful and good to use in care? And with that spirit of how do we improve, I'm really proud to announce we have a next-generation plaque algorithm coming out. This is under review with the FDA, but we have shown that it has an improvement in detecting plaque, as well as giving a real next-level visualization of plaque. And I'll show what that looks like here. So in our product, what you will see is now in 3D, precisely rendered. You see non-calcified plaque in yellow, calcified plaque in blue, the ability to navigate this data and at a glance really understand is the plaque focal or diffuse, is it eccentric, synchronized, of course, with the images, and with Heartflow synchronized with FFRCT as well, with lesion-specific FFR values. The nice thing about this 3D rendering is it really gives you this sort of quick at-a-glance fingerprint or understanding of the coronary disease. You can see the patient on the left has a focal, non-calcified and low attenuation plaque lesion. Patient in the middle has a lot of diffuse calcium. Patient on the right has a lot of diffuse plaque, but more non-calcified. And very quickly, without even looking at the images, you can observe that. And then, of course, complemented with FFRCT, we can see that one of those, only one, is actually lesion-specific in a way that matters with a 0.65 value of FFRCT. And from a clinical evidence perspective, I'm also really happy to share we've now done the largest study of coronary CT with over 270,000 patients. These were all-comer patients getting coronary CTs. They were analyzed with this next-generation algorithm. And we now have this new understanding of the distribution of coronary disease so that when you get a plaque value from Heartflow, you can really understand how does it compare to an incredibly large and diverse population. This also becomes the engine for how we think about monitoring coronary disease. This is a patient example with scans at baseline in 26 months, and you can see quantitatively non-calcified plaque went down and calcified plaque went up. That's good. That means good response to medical therapy. But also now we get an understanding of the AI and visual correlation to that. You can see the yellow non-calcified plaque shrinking in follow-up, and the blue calcified plaque is becoming more extensive. So that precision of being able to tie the numbers and visuals is really nice to be able to understand. Now, all these new insights obviously create a lot of opportunity in understanding coronary disease, but I also want to be realistic that it creates a lot more information to report and dictate. The good news is there's RVUs for FFRCT, there's RVUs coming for plaque, but the other thing we're doing at Heartflow is working on automated reporting to help you do this at scale. And so we're building technology to take all the values that you can get from Heartflow and populate them directly into your report templates. And I don't mean copying and pasting or doing anything like that, but really it automatically shows up for you at the time that you need to report. So my hope is that would allow you to spend more time on the images and the clinical insights and understanding what does it really mean for patients and less on some of the more mundane aspects of reporting that we can help automate for you. Now, some of these patients may end up in the cath lab, like the one I showed earlier with a positive FFRCT. And I'll share a quote here from Carlos Collet, who's the lead investigator of the P4 randomized controlled trial looking at these CT-guided PCI methods. We've been a part of this trial from the outset. And as interventional cardiologists, we traditionally have 30 seconds to decide what to do with coronaries. Much less time than you would spend even looking at a coronary CT. But with CT-guided PCI, we're shifting to proactive decision-making. The challenge here, though, of course, is there's just such a diversity of tools. And to think of bringing this into scale in clinical practice, the idea of interventionalists, other than people like Carlos and some in the study, learning the workstation and learning all 4 different tools and compiling all the information together is not quite practical. So at Heartflow, we're building the single, simple solution for this, an AI platform to really plan interventions and really leveraging a lot of the strengths of Heartflow. This brings together the patient's anatomy, lesion-specific FFR, plaque information. You can see a FFRCT pullback akin to what you'd do in a cath lab, a pullback analogy to IVUS, vessel dimensions of length of where you may place a stent and coronary lumen size. So really all-in-one tool to help you plan an intervention. And then we get to this concept of predicting risk and prevention, and there's the traditional approach of you take a whole population, use population risk factors, and then you sort of smear therapy across large groups of patients. We see an opportunity to shift this towards having a truly precise understanding of a patient's risk, whereby using a coronary CT and all the insights you can derive from it, having an AI prediction of the patient's risk, a singular number, like a % risk over the coming years, and then really tailoring the therapy to that patient's individualized risk of their coronary disease. We're doing a lot of research at this at Heartflow. I can really only share what's public and published at the moment, but we've shown this method of taking all these insights from a coronary CT, blood flow metrics, myocardial metrics, plaque quantification, stenosis, and training algorithms to learn how they all really interact and predicting ultimately what causes ACS. And we've shown this is a better predictor than just using plaque or stenosis. And finally, I'd just like to thank all of you that have been on this journey with us. As I mentioned, I really can't imagine our product would be what it is today if we hadn't been able to make the improvements through the learnings we've had with you and all the data. And I also can't imagine it'll be the product that's to come. So really appreciate all of you joining us on really helping change coronary care. Thank you.
I'm going to spend the next 10 or so minutes talking about imaging that informs the future. So the email that we got from the SCCT was to don't emphasize your product so much. Tell us where the field is going in the next 5 years. And so one thing that I had been accused of was that somebody told me, like, you're the only guy who comes to imaging conferences and never shows any images. And I said, well, fundamentally, I don't really care what the image looks like. I care about the data that we can get from it and how it can guide care to improve patient outcomes. So I will show some images, but I think that this is ultimately where I see the field going in the next 5 years. So let me just take you through these 5 bullet points. In 2010, there was a very famous technologist. He's an entrepreneur, and now he's an investor. But he had a quote that he said, software is eating the world. And I think that, 15 years later, AI is going to eat the world. Like, it's amazing to me just in the day-to-day interactions with all of these companies that we come along and these technologies, how much AI is really changing the way we're going to practice medicine. And so much of it is unbeknownst to us because we don't see it. But in about 2-3 years, all of a sudden, there's just going to be this huge deluge of all this AI that's available for us. And so, this is what's available today. Like, if you were at the AI ML session yesterday, my colleague and friend Udo Hoffman was the one who presented a lot of the technologies that we have infused into our product portfolios. But what we can already do today is we don't have to go through multi-phases. The AI will do that for you. It's going to look for the best image quality. It's going to look for the best image quality by artery. It's going to cherry pick all the best image qualities, and then it's going to stitch them all together, so you don't have to do that manually. What it also allows you to do is get the highest resolution images. And so what do I mean by that? Like, if you look at some of the softwares out there, you can get down to about 2, maybe 1.9 millimeters of vessel. Now you can get down to 1.3, 1.2 millimeters of vessel. And that increases the visualization of by about 80% of the vasculature. We can now look at atherosclerosis. We can look at stenosis in an OCT-like view, right? So optical coherence tomography measures stenosis much more accurately than we have typically done by invasive angiography. We can do plaque-based FFR. If you've looked and followed the literature for the last 15 years, like, we've seen a ton of data that shows that it really is the plaque that influences whether or not a vessel is ischemic or not. Get measures of myocardial blood flow, plan for PCI, disease track, automate reports, curate data at scale, and so on. I think the most important thing that we really wanted to do with our platform was to create a platform, to make something that, like, we could speak to every single stakeholder in the care pathway, whether it's the patient, the primary care doctor, the general cardiologist, the preventive cardiologist, the interventional cardiologist, the radiologist, and so on. And so if you haven't seen our platform, please come by our booth and we can show you that. Where we're looking now, though, is the future. I think that here are at least 6 things that are going to happen over the next 5 years. We're going to move out of the projection domain into the image domain, right? So all of the physics-based improvements that we saw in improving image quality, improving resolution, temporal, spatial, denoising, et cetera, all came in the binary code of that CT scanner. Now what we can do is we can go to the images themselves, and we're going to get to ultra-high resolution, where you're going to see resolution similar to IVUS, without a photon counting CT scanner, just with a regular energy integrating detector scanner. You're going to get super high resolutions. You're going to be able to reduce image noise so that you can do sub-millisievert image acquisitions at scale. You're going to be able to de-bloom calcium with a click of a button. Like, so this whole bane of CT's existence, this whole blooming of calcium, it will not exist in 5 years. And then the other thing is we're going to start doing serial CTs, right? So you're going to be able to figure out how to normalize the CT scan pixel to pixel so you can compare apples to apples rather than apples to oranges if you have a 64 slice scan on the first image, but then maybe a photon counting CT scan on the next image. You will be able to harmonize those. And then you'll be able to fuse that all with multimodality imaging. So that's great, like, that gives us images, but I think what we really need to do is to shift the paradigm. And I don't think we're starting to shift the paradigm. I think the paradigm shift has already started like 5-7 years ago. But one thing I think we're going to do that we've learned with CT is we're going to shift away from surrogates, right? So you saw the PREVENT equation, the ASCVD pooled cohorts equations, all these risk calculators that use risk factors have not worked. And when you look at the risk factors, in this case, for this slide, it's looking at LDL cholesterol, it doesn't work. We are failing our patients. Like, when you look, 80% of the people with coronary disease have normal LDL. Like, 80% of the people who have heart attacks versus don't have heart attacks, there's an 80% overlap in LDL. And then when we start to treat patients and lower their LDL, we get a 20% relative risk reduction. What does that mean? That means 4 out of 5 people are failing. We are giving them a medicine, we are lowering their risk factor, and yet 4 out of 5 people don't benefit from that evaluation. So instead, what we're going to do is we're going to go to evaluations using actual disease, right? So here's a woman who's like asymptomatic, no risk factors. And then when you start to look at what she looks like, you can see that she's got an enormous amount of disease. She's got an enormous amount of non-calcified disease. She's got an enormous amount of low attenuation non-calcified disease. She's got severe stenosis, and she's got ischemia, and she's completely asymptomatic. These are the people we miss, right? And so what we're going to do is we're going to move away from surrogates. We're also going to move away from symptoms. It's always bothered me that we as a field have been so symptom-driven in our approach to evaluating whether or not somebody's sick or not. What we should be is disease-focused rather than symptom-driven. So this is a paper that Nick Nurmohamed, I don't know if he's here or not, but published in the European Heart Journal just a couple of weeks ago. And what he did was he took 4.9 million heart attacks across the US, and he asked a couple of very simple questions. Amongst these patients, these 5 million heart attacks, what percentage of them had any symptoms before their event? It turns out the majority of people, in blue, did not have a single symptom before their heart attack event. When you look at the blue people, 30% of them don't have a single risk factor. 50% of them don't go to doctors. Why would they? They don't have risk factors or symptoms. And that means that 75% of them aren't treated with any medical therapy at all, and they're sicker. You can see there's a higher rate of ST elevation myocardial infarction in these patients. So we've got to move away from symptoms because the greatest unmet need is in that majority of patients who will never have a symptom before their event. Here it's illustrated, right, on two patients, one on the left that has chest pain, a bunch of risk factors, and is essentially normal. And then you've got the person on the right who's like, no symptoms, no coronary disease risk factors, and as sick as all. Tons of plaque, tons of ischemia, tons of severe stenosis. And so I think we just need to get away from symptoms. If you ask yourself, what's the prevalence of silent ischemia out in the US? It's probably in the 50 to 80 million people have some degree of silent ischemia, severe disease that we're just not detecting. And that's why they come in with their heart attacks, but without ever seeing a doctor. I think if we can start to measure actual disease, then we should track actual disease to quantitative success, right? So this was based on a study that we had done. We had published, it was called Paradigm, serial CT study in about 1,200 patients about 3 years apart. And what we wanted to do, we treated about half of them with statins and half of them without. And what you saw was on the left, like the statins do somehow slow the progression of plaque, but not by very much. You can see the p-value is 0.039, barely significant. And the reason for that is they accelerate calcium, and then they decelerate non-calcium. What do? They transform the non-calcified plaque into calcified plaque. That allows us to achieve two therapeutic goals that we will adopt in the next 5 years. Number one, if you come in with 100 units of plaque, I'm going to keep you at 100 units of plaque. I'm going to stop new disease from forming. But two, amongst the 100 units of plaque that exists, I'm going to turn all the non-calcified plaques into calcified plaques and stabilize it. That study that we did with statins has been now replicated with all of those different medications you see on the right, as well as with lifestyle modifications like a low-sodium diet, increased physical activity. All of the good things that we do for patients have a common phenotypic effect of transforming non-calcified plaque into calcified plaque and slowing its progression. Here's an example. This is actually a cardiologist who came in 2020. He was on a statin, came in with 260 units of plaque. And what we said was, look, we're going to keep your 260 at 260. We put him on a PCSK9 inhibitor. 3 years he came back, still 260 units of plaque. But what you can see is that in the green box, the non-calcified plaques dropped by 82, and then the calcified plaques increased by 80. So he's not only stopped new disease from forming, but he also transformed his pre-existing disease from dangerous to stable. And then what you can see is that that's obviously on a patient level, but you can do it at the lesion level too. So you can watch these high-risk plaques turn stable over time. If we can get away from surrogates, if we can get away from symptoms, and if we can track actual disease, then I think we're ready. You heard the debate that Todd and Kelly had earlier today, whether or not we're ready for universal screening. And I think that both of them were right. But if I had to choose one to side with, I'd side with Kelly. Because Kelly, what he said was like, I'm not saying that we shouldn't screen the world with for heart disease using CT angiography. I'm just saying that we're not ready for it today. And I think that he's right, because what you need to do is perform a large-scale randomized trial. But what he was definitely right, what Todd was right about, was that we've gone away from all these surrogates, like breast exams or fecal occult blood testing, chest X-ray. We went to direct advanced imaging to directly visualize somebody's disease so we know whether or not we could actually impact their outcome in a favorable fashion. We do not do that in heart disease yet. We rely on surrogates like risk factors. factors. We rely on symptoms, which again misses half the people, and we rely on stress tests historically, which miss over 75% of lesions that cause heart attack. So right now we're about, I think, 4,500 patients enrolled into a large-scale randomized controlled trial called Transform. And the goal of Transform is to achieve universal worldwide screening of heart disease. I think this trial is taking patients who are completely asymptomatic. They're not, oh, actually, they're not even patients. They're people, right? They're the people that you're walking around the grocery store playing Little League on the weekends, and they get randomized to the standard of care, which is checking risk factors of disease, versus a disease-based care paradigm where they undergo imaging and they undergo the Cleerly analysis to look for atherosclerosis, stenosis, and ischemia, and to see whether or not that knowledge can actually improve patient event-free survival. So, by the end of 5 years, that trial will be well done, and hopefully it will be positive, and hopefully we can influence the guidelines so that we can go out and achieve universal worldwide screening. Thank you very much.
Thanks, Vinita and Ronen. Thanks to the Society for inviting me to represent Elucid. I'm CEO of Elucid. We want to be on the front edge of this movement, a movement that's been created by many people in this room, of going from treating risk factors to treating individuals, personalized precision medicine. And I can say that proud to be with trailblazers like Heartflow and Cleerly, that we want to do steps of progress along the way with them, and in the end of the day, the patient wins. So I'm going to talk to you about a few things on Elucid and what we're doing today and what we'll have in the future. What I want to share with you is how we believe lesion level information of physiology and morphology will give you actionable risk assessment. Well, I want to share with you how we work with Dr. Renu Vermani, who many of you know, who developed IVIS-VH to develop CT-VH. We're the only plaque product with ground truth of histology and the only non-invasive FDA-cleared device to actually measure and quantify the lipid-rich necrotic core. And then, as Jim was saying, we take our plaque information from CT-VH into an AI algorithm for an accurate prediction of FFR. That's a product in development that we're getting ready to bring to you next year. And that's what we have in the current state. We want to give you the state-of-the-art FFR and plaque in the same product. I'll show you the clinical resolution of that and how that benefits you as a clinician, and we'll rely on some debate that Todd and Ed had in the last session, and I'll let you decide. And then I'll talk to you about the future. I mean, we, as our friends at Cleerly and Heartflow, we owe this organization, this community, randomized clinical trials that get us to a place that we believe it's not like FFR is for late-stage disease to the cath lab. It's not like plaque is for medical decision-making. It's actually, you want the marriage of FFR and plaque for all stages of disease to make those clinical decisions. And I'll share with you a heuristic that we have, retrospective studies that were ongoing, that will be hypothesis-driven for randomized clinical trials in the future. We're all here for the same reason, right? 18.5 million lives lost every year. Heart attack and stroke still the #1 killer. Amazing interventions have been developed in the last 10 years, amazing drug therapy, but this is still the #1, and the shame is that World Health will tell you 80 to 90% of those are preventable. So why are we not just preventing them? The good news is that societies and guidelines have changed to say, things like nuclear cardiology that are invasive and great, but miss a lot of real plaque because it's an inherent indirect measure of structural perfusion. Going to the world of CCTA. So cardiac CCTA we see growing. We see ourselves, Heartflow and Cleerly, being able to give you more information in that. And, it is only 8%, by the way. 8% of CCTAs today get an AI add-on. We look to you guys to help bring more information to your clinical care. And hopefully I can share with you how that can benefit your decision-making. For Elucid, we believe that risk assessment, it starts and ends with plaque. As you know, the pathophysiology of how does cholesterol get to heart attack has been well defined. A lot of it has to do with the lipid-rich necrotic core, that inflammatory part of the plaque that actually erodes and kills cells in that thin fibrous cap. And then actually why I say lesion level FFR is important, and maybe more delta FFR, but that pressure gradient across that plaque has to be strong enough to rupture that, and that causes a thrombotic event, that causes, type 1 MI. There's no vessel that collapses for a type 1 MI. It's always a single lesion that ruptures, and a lot of that is driven by that lipid-rich necrotic core as well as the FFR gradient across that lesion. So we want to give you the ability to understand how to go lesion level, how to quantify calcified, non-calcified, as well as that inflammatory lipid-rich necrotic core, and how to look at this over time to see if your treatments are regressing or is it progressing, and maybe you should think about revascularization. Now, we talk about risk factors. These are not going away. Overall plaque burden and type kind of give you the neighborhood of this, bad player lesion. Then, from an individual lesion level, we believe you need to know both morphology, calcified, non-calcified, LRNC, like is it touching, is it starting to encompass the lumen is probably a good question, and other morphological features that we're going to elucidate. And then physiology, whether it's delta FFR, other physiological features, as well as the change over time. So, the idea of tracking in serial scans, very much in our roadmap. And I want to give you where we are in this. We talk about a movement. We look at this movement as starting, Framingham study. We talked about risk factors and managing patients based upon risk factors, not exactly adequate. Maybe it was great 20 years ago when drug therapy was just Lipitor and baby aspirin, so you can initiate care with looking at risk factors. But at this point, the communities are going towards, let's not look at treating LDL in the blood, let's actually treat LDL that we can visualize building up on the vessels and going to overall total plaque burden. And I've got to thank, Michelle Williams and David Newby with Scott Hart-2. You heard Jim Min talk about the Transform trials. These are going to be revolutionary for the field to help us move forward and understand a better approach. And then what we see as that step of progress is to take that focal point a little bit deeper and adding to this individual lesion level information and understanding risk. And what you can hear tonight or tomorrow night, if you're around at 7 o'clock, Dr. Miramati, talk about some prospective trials of HALT series. So very precise medical decision-making based upon lesion level information and physiology. Our preview registry to look at the ability to stabilize plaque with medical treatment, or if natural history is going to beat you and it's going to rupture. And based upon that, we have a randomized clinical trial to prove out these hypotheses. So end of the day, we think lesion level plus overall plaque burden, we're not getting rid of risk factors. They're just going to play in a different way. Going backwards, we'll actually get to healthier patients, and healthier patients will get to healthier populations. And I believe this is the way that you're going to say, how do you treat Kelly different than Kelly's brother, even though risk factors are the same, but lesions are different. So we look at advancing the plaque first with our CT virtual histology. I talk about plaque 1.0 being Hounsfield unit assessment that is ground truth by visual assessment of expert graders. And this is an amazing technological innovation. The idea that we could take an expert CT level 3 reader and bring to the masses where there are not a lot of CT level 3 readers is amazing. Some limitations though. I mean, you're building a model based upon a subjective assessment. As you know, 2 graders are going to have variability in how they grade a scan, and even the same grader on different days may vary on how they grade a scan. That visual assessment and variability, the model will never be better than that. So they use this technology to set cutoffs on Hounsfield units, 30 LAP, 130 calcified. And what we can show you in histology is actually biology doesn't listen to hard cutoffs. There's actually diffusion across different Hounsfield units for different tissue types. And that another limitation is just the human eye. The human eye cannot see lipid-rich necrotic core, so there's a technical definition of low attenuation plaque. And if there's a signal there, you may be concerned, but you may not be, because also healthy wall, fibrous tissue, fatty tissue, and fibrofatty tissue also live down there. So Elucid worked with Dr. Renu Vermani to say, how do we go to plaque 2.0 and actually see beyond what the human eye can see? Take that expert reader and see what they can't see with the human eye. And we did the study of patient with CT scan, take that CT, take the vessel, send her Renu. She sectioned it, stained it, and as we all know, it stains, each tissue type stains differently. So you go to an objective, quantifiable ground truth, and we had CT slice meet pathology slice over and over again to build the model, so that now we have an algorithm that actually can see the lipid-rich necrotic core, quantify it at the lesion level, and that's going to help the expert reader add to their armamentarium of what they can see with their eye. We see on the left is our histology validation. It's in press, but all the correlation to histology is very well achieved, even our lipid-rich necrotic core, R.89. And on the Hounsfield unit side, we see the REVEAL plaque study with a Hounsfield unit basis, just saying that, IVUS LAP is not Hounsfield unit LAP, so it's unclear exactly which one of those is the measure you're going to go with. As Jim said, we're not the only people that believe that we can build a better FFR with AI and plaque input rather than just computational fluid dynamics. Computational fluid dynamics is amazing, It does luminal diameter and does a lot of math of the Navier-Stokes equations. It doesn't take into account that there's plaque in the wall, and what we believe is that the amount of plaque and the type of plaque actually matter in the vasodilation capability of that vessel, and that dramatically impacts flow when you talk about sicker vessels. And by the way, some Nears-Ivers shows that actually lipid-rich necrotic core is the biggest impact on vasodilation and endothelial dysfunction. So what we did is we took our plaque algorithm, we got ground truth CT scans with invasive FFR that was done in 2 months, and we built a model that was able to take a plaque input, obviously looks at the CT scan for stenosis, combines that to be able to predict FFR as opposed to calculation of FFR. So AI prediction is very clear. We're going to give you a viewer. This is to be approved. Our plaque product is approved. FFR's in the process of being submitted to FDA. You see here a case, left system. You're interested in it because there's some change in color. If you click on that, you'll get a direct 0.78 FFR value. And then what we allow you to do is actually go back to the raw CT scan. So let's be fully transparent about it. You can see where Elucid put the lumen and the wall, and you can agree or disagree in that stenosis, the positive remodeling. You see that remodeling, you probably say, okay, there's probably lipid-rich necrotic core there. And then that's in this yellow non-calcified matrix, as well as the calcified in blue. So with that, you get an FFR value that's fully integrated with your plaque, and then you can see the building blocks of how we got to, say, a 0.78 FFR, and you can make a clinical decision. Some doctors say, I would go with aggressive medical therapy, high statin, ezetimibe, PCSK9, anti-inflammatory, dual platelet therapy, bring them back in a year. Some doctors say, I would put a stent in here, and that's a decision you can make. They can obviously make the length of the stent and not land in that lipid-rich necrotic core. And where I was going with, today, Dr. Nichols, Dr. Valines was talking about, can AI guide clinical decisions? You make the judge. If you had this today, you had their LDL, their LPA, and you had this scan, would you have a different vision of this case if you had this in front of you? So with that, I'll just go off and say, in the future, we're going to bring you that today, or in the next 6 months, FFR on top of plaque, fully integrated, fully transparent. You can go back and forth. You don't need to start finding your plaque report, your FFR report, go to Terra Recon to go figure out where the lesion is. It's all interactive, built all together. And in the future, we see showing you that FFR is not a late stage, plaque is not early stage. It's the combination. Jaga Narula Motoyama, we see FFR positive, HR positive, clear benefit of stenting over medical therapy. Actually, FFR positive, HRP negative, you actually are just as fine doing medical therapy. And of course, Greg's shown in the prevent trials, that upper box. We have a lot of work together with those folks to bring some trials to bear. And with that, I want to share with you, where we started. These are the pieces that we intend to bring to Elucid. And we are very happy to be on this journey with SCCT to get to personalized medicine. Thank you.
All right. So once again, thank you very much. Besides being the CMO of Circle, I'm also a clinical cardiologist. I see patients every day. I'm reading CT scans, reading CMRs. And so I really look forward to presenting this talk today about risk stratification. So when I'm sitting across from my patient and discussing risk, I realize, what does that mean? What does risk mean when it comes to medical risk? We're not talking about the likelihood of someone getting hit by a bus or the likelihood of them having colon cancer because they're seeing a cardiologist. Really, from the patient perspective, they're talking about, am I going to have a heart attack and when am I going to die? And that's really what it comes down to for the patient when you're sitting across from them when you're talking about risk. But we all know that it's more complicated than that. From a physician standpoint, when we think about risk, it's much more detailed. Major adverse cardiovascular events. And that can be defined differently depending on the study that you look at. But death and myocardial infarction, that's pretty straightforward. Arrhythmias, that can be a risk also. Ventricular tachycardia, atrial fibrillation with strokes. Revascularization, the risk for someone to have a stent put in or possibly bypass surgery, develop heart failure, or be hospitalized for heart failure or other cardiac event. So much more detailed. And so we think more about those causes of the risk. That could be, like I said, a coronary event. Perhaps that's even valvular heart disease that leads to revascularization with a CABG and a valve replacement, or just simply a valve replacement, or a hospital admission for acute heart failure from some severe mitral regurgitation. In addition, there's cardiomyopathy with a low ejection fraction that places someone at a risk for sudden cardiac death, and again, repeat hospitalizations. So putting all of that into this slide, how can cardiac CT then identify risk? Well, there's much more to it than if someone's having a heart attack or a stroke, or a heart attack or just chest pain or death. So obviously, like the other speakers I've talked about, there's coronary stenosis and flow, very critical. That's the core part of cardiac CT, right? And so with CT-FFR, clearly has been shown there's outcomes, and it can do a great job of differentiating between who's going to have an event and who's not. Plaque analysis, that's a big topic for SCCT this round. Plaque analysis definitely you can help advise your patient about their risks again, and hopefully that'll lead to some sort of lifestyle changes. Perhaps you're going to change some medicine to try to influence that risk of some sort of cardiac event as well. And plaque, as has been discussed before, it gets very detailed, right? There's a lot of different types of plaques that are in there. So that's where plaque analysis is very powerful at that. But there are other things that go outside of the coronary arteries as well. So within structural heart disease, valvular heart disease, in this particular graph that I have with aortic valve calcification, that's linked to survival as well. So that's another type of risk assessment that is outside of the coronaries that the cardiac CT does a great job of looking at. Cardiac mass and thrombus, sometimes we use a cardiac CT to find either thrombus within the left atrial appendage or perhaps in the left ventricle that can lead to strokes and debilitate patients that way. And once again, I did mention about left atrial appendage thrombus, and in particular with Circle, we have this Watchman TruePlan module that can assist with that, can assist with planning the placement of the Watchman device, sizing up the left atrium. And that's an example that I have here. And you can also use it post-device as well for looking at how well a device is seated and looking for leaks rather than sometimes a TEE. So with our product that we have, it provides a comprehensive platform for supporting cardiac CT. What does comprehensive mean? Well, we're looking at all those various aspects of risk that is included, not just when it comes to the coronary, but assessing the valves. In addition, valve planning for left atrial appendage, for Watchman planning, and all of those particular elements that go into risk. So it aids with that, aids with the diagnosis of disease as well, not just with risk assessment, and for the interventional procedure planning as well. And then the other point that I would like to make about our particular product is that it's an in-house solution as well. And what does that mean, an in-house solution? Well, that means that our particular studies do not have to be sent out to be processed. And so I think that's a critical aspect to actually think about. And the reason why I bring that up is because all these things cost money. If you're going to have a plaque analysis performed, you're going to have send off for a TAVI planning for a different site, that costs money, and someone has to pay for that. Is it going to be insurance that's going to pay for that? Or is it going to be the patient that's going to pay for that cost? Well, if you keep this particular planning inside, sometimes it doesn't have to cost money, because then you get to decide if are you going to bill the patient for this particular process or not bill for that particular process. You could do this work pro bono so that you can make plaque analysis available to your entire population of patients, not just those who are insured or are wealthy, but to that barista that served your coffee today. And so there's a lot of different advantages that you can have that goes along with that. So I think that in particular with Circle, it provides us more comprehensive tool of risk assessment, so not just for the coronaries, but for structural and left atrial appendage, and really can provide this comprehensive care to your entire patient population, and not necessarily to select particular individuals who can afford it. Thank you.
We would like to invite all the speakers up here for the panel, and then if you have any questions, please do come to the mics.
Guess we'll share.
Right.
giving up your chairs. Okay.
Any questions from the audience? I can get started with a question or two. So one of the things we have seen that has come up again and again in various talks is the issue of validation of plaque and plaque quantification across various platforms, because plaque means different things on different platforms. So I wonder, how are you all going to resolve that?
Should I take a first crack at it? So first, ours was validated against the ground truth of histology, which is the gold standard for plaque characterization. Just living patients don't want that gold standard done on them. We do have the NEARS IVUS. We're going to do the comparison to show the coherence of those. So ground truth validation is great. Bringing it back to tools that the cardiologists are familiar with is also going to be great. And that's how we hope to demonstrate the reality of what we're seeing in the CT scan, because it's what you see in that pathology.
Yeah, I'll add my opinion as well. I think it's a really important question first, because how do you trust the information without validation? That's always key to these technologies. And choosing ground truth is important. I suppose we chose the living patient ground truth of IVUS, which I think has certainly been well established over the years, and we wanted to do it in patients who are alive getting coronary CTs as well. We did prospective evidence of multi-center studies, a large powered study, and I think that sets a certain bar, and so it, to me, is something that's open for any vendors to go do a similar type of study as well and compare, and then you'd have data to compare how different technologies exist.
I would say for our product, we used expert readers, so we did not do any histology or any other invasive study for that. And so we had our readers have to define the vascular border, define the plaque, and such. And so when you, as a reader, when you see the analysis that's performed, you either can agree or disagree, just like the expert readers, and you can adjust those particular borders if they're out of line or what have you. And so we use that. That was our ground truth, was basically the human expert.
Yeah, I mean, it's all great. Everybody has used a different ground truth, and it's how do we reconcile this across your ground truths? That's the question. And and I think it will remain a question.
The G photon counting scanner will do it.
Yeah, I'll say there are some working groups looking at this, so I think we'll keep answering this together with a combination of academics and industry. So I think it's an important question, as you said.
Thank you. Any questions from the audience? Did you have anything?
So maybe I'll ask a sensitive question because, definitely in the US, but especially outside of the US, it's kind of challenging to add the cost of those ancillary tests to regular coronary CT angiography. How do you see the future of us making it real, making it available for many of us, as we are all excited about those technologies? What do you think?
Well, kind of reiterating my point, at least with the in-house solution, again, you can choose yourself to bill for that or not bill for that. I also think that the vendors here at the table, it's a great opportunity to also provide pro bono type of studies for individuals that can't pay for that as part of the package. As well, it's very expensive. The plaque analysis in particular is very expensive. You're adding that on to a regular CT scan for an individual, and I really don't think a patient would see the value of plaque analysis at this point, would not be willing to pay for it unless they had a lot of money to do so. But if that cost was reduced, or you just provided that service for free or at a significantly reduced cost, I think that's really, we're going to get to the level where this could be a screening exam.
Yeah, I'll share our experience because we have some international usage as well as the US, and I think this all comes down to health economics. So there's very well-established data. We've done multiple studies on this of showing FFRCT can be net cost-effective to the healthcare system. So in the US, for example, there's 99.5% covered lives. In the NHS, we have wide adoption because they've decided as a national health system to pay for it, similar in Japan. So the places where it's not there yet, unfortunately, haven't made that decision within the framework of their health system, looking at the evidence and deciding this is something that should be funded at a national level. And many of these things take time. It's different decisions based on the country, but I would certainly encourage anyone to start thinking about and working on the advocacy to that, because there's really substantial evidence to show the cost effectiveness.
Yeah, I would just say, Heartflow definitely did an amazing job in outcomes and clinically and economically. UK, Japan certainly covered more. I hear 6 other countries in Europe are considering coverage. So certainly plaque has to get to that point. And in the United States, an MI, if you live, will cost the health system $500,000. So the hazard ratio of kind of benefit to number of scans needed is going to be important. And at least, with some data Dr. Ahmadi has, prior family history in a screening modality, just looking at less than 60 CT scans saves a heart attack. But there's much more work to be done on kind of the great outcome studies that Heartflow's done on FFRCT.
Any questions from the audience? So one generic question I had for all of you is based on a session we had earlier today on the environmental impact of imaging and the use of AI and big data processing and pretty significant cost to the environment. So with regard to the life cycle assessment and how we can reduce that and how that translates into profits for in the clinical workflow for an institution, how are you addressing that? Are you addressing that within your, products? And how could what do you think needs to be done in that arena?
It's funny because we talked to NVIDIA and they don't think we use enough compute power to make it interesting for their chips. So AI for sure is less compute power than, say, computational fluid dynamics on a finite element mesh. And then on the radiation exposure, our friends over here has got less than 2 millisievert scans. It's amazing. So, I think the future is definitely moving in the direction of less impact environmentally. And, I don't think we're in a bad position today, but debatable.
I can answer that, I guess, from the perspective of the equipment manufacturers. I think there's been obviously a big push for more environmentally conscious designs. We all work very hard to lower the energy usage of our products, that they can generally go into sleep modes, consume less power-hungry systems. I think all the vendors are working on solutions to make their systems recyclable, remove hazardous materials from their products. When a system's not used anymore, we bring them back and put them through recycling systems. And I think in general, we also, the AI that we are building is much more contained than, the macro, Amazons and Googles and NVIDIAs of the world. So our algorithms are designed to be optimized and fast and small. They typically run locally on the product and have less of a footprint than some of these other solutions.
Yeah, I would echo exactly that as well. On the hardware side, of course, having products that are as energy efficient as possible, but also the software side, right? To build software which is efficient and maybe even on-premises first approach, because of course, the more you send to the cloud, you're again sending back and forth and staying online. And again, you also have to then review those results, all of that. If you can automate as much as you can and with efficient algorithms that you utilize the least amount of thing, and also precise algorithms, so you don't have to spend so much time reviewing the cases as well, would be the way forward to have that impact potentially.
Yeah.
I have one slightly other different view, and I used to travel an awful lot, like every week almost. And I think a lot has changed in recent years with that. We do a lot more digital meetings. I probably fly half as much as I used to. So there is this other kind of aspect of business impact and that type of piece of it as well, that we're just naturally adopting more digital communication tools.
Yeah, and I'll just say I agree with an on-site solution. We're using just what the user has, their graphics card that they're using, so it's really not that significant of a demand. I think there's probably a lot more energy that went into building that model than there is in the utilization at this point.
Yeah. Thank you.